Hi, and welcome to Next Steps. Next Steps is a series of conferences presented by the Center for Autism Research at the Children's Hospital of Philadelphia. These presentations are offered to families, professionals, and anyone interested in learning about autism spectrum disorder. Our first video is What is Autism? By Ashley deMarchena from the October 29, 2014 presentation of Next Steps for Families of Young Children After Receiving an Autism Spectrum Diagnosis. We hope you enjoy the program. We hope to update the recordings and post more as often as possible. Thank you.
So I'm Ashley deMarchena. I'm a postdoc fellow. My clinical focus is on early diagnosis. So I've diagnosed many children with autism, and I'm really interested in how we improve that diagnostic process, both to make it smooth and easy for families and do a really good job, but also to diagnose as many kids as possible as early as possible, because we really know that an early diagnosis has a big impact on children's outcomes and their response to intervention. And I'll just say from the beginning that sometimes I'm a little nervous when I give this workshop, because I really do think of this as my most important audience that I speak to. So I hope that I can explain a little bit about not just what is autism, because I know everyone here in the room knows what that means to some extent, but also how we make the diagnosis, how we've decided on these symptoms, and what are some of the other, how these symptoms might change over time and be associated with other things that are good to keep your eye out for. We've relatively recently, it's not quite as recent anymore, but about a year and a half ago, we've revised some of the diagnostic criteria for autism. And I'll say right off the bat, name-wise, we've gotten a little confused in our field. We're trying to iron that out, but the official name of the diagnosis now is Autism Spectrum Disorder. So you might see that in reports for your kids or kind of in diagnostic summaries of your kids from your doctors. The term, sometimes we abbreviate that as ASD, so I might say ASD, or I might just say autism. I mean the same thing, which is this broad diagnosis of autism spectrum disorder. Now, part of the reason we've gone to this name of a spectrum disorder is that we've come to recognize that autism is really quite complex, and that it varies among kids. And it can vary in a couple of different ways. So one way that it varies is that the symptoms themselves, which I'll get into in quite a bit of detail, can vary in severity for kids. So some kids might have mild autism symptoms, whereas other kids might have symptoms that really get in their way a lot more. That's one way that the diagnosis can be on a spectrum. But then the other way is that there are different kind of associated features of autism. The one that we think of often is intellectual functioning. So how is your child's development? So some children can have pretty significant autism symptoms, but their cognitive skills, their developmental skills are on track with where they are with other children their age. Other children with autism tend to have some cognitive delays, in particular language delays in young children, and that can also affect their ability to function in the family and function in school and out in the world. So that's the other major way that we really see this as a spectrum. And we've modified our diagnostic criteria to try and capture all of those kids under the same umbrella, because we really do see this pattern, which is characterized by difficulties with social interaction, that characterizes those kids with the mild autism symptoms and the more significant symptoms, and the intact cognitive or developmental skills and the more challenging intellectual skills. Autism now falls under this category that we call neurodevelopmental disorders. So that's that first thing up there. And basically what that name comes from is the fact that we now believe autism is really something that affects the central nervous system, or the development of the brain. And we call it neurodevelopmental because the diagnosis is something that we believe is present from very early on in life. So not necessarily birth, but probably within the first year, we expect these symptoms to be present to some degree. So if someone as an adult starts showing symptoms that are similar to autism, we wouldn't call that autism. We would think of something else to describe that. Now, not all children are diagnosed very young, because their symptoms might not be as visible till they're older, but we really do think of the pattern as emerging at least within the first 3 years of life generally. Okay, as you'll see in a lot of detail, that second part there is that we really define autism as being a diagnosis that's characterized by weaknesses in social interaction skills, so back and forth social interaction and communication. Another important part of the diagnosis is that there are a pattern of repetitive behaviors or interests that go along with these weaknesses in social skills. When we make a diagnosis, we're really looking for a pattern of symptoms. If a kid has one or two symptoms that are similar to autism, we wouldn't make a diagnosis. We would keep our eye on that kid, but really we see these two separate things coming together, which are weak social communication skills and then the presence of some unusual behaviors like repetitive behaviors or interests. And overall, the way we look for these things is two ways. So those of you who have gone through the diagnostic process have probably observed this, although it might not have been made explicit. So the two things that we're really doing when we're making a diagnosis are, as the clinicians ourselves, we're observing your kids and we're playing with them and we're trying to see, can we ourselves see some of these symptoms happening in real time? And then the other thing is we're talking to you. So we're talking to the parents and we want to know, I saw your kid doing this repetitive thing. Is that happening in other contexts? We don't want to get the sense that something that we saw just one time makes a diagnosis. We want to make sure that it's happening in the child's life and is interfering in some way with their functioning. Finally, autism does tend to be a lifelong disability. Symptoms can change, and oftentimes they improve with time, although that's not the case in every child. But generally, the symptoms do not completely go away. So as I go through the symptoms themselves, I'll try to give some examples of how those can look over developmental time, because that's really a challenge for us too. So as you can imagine, social skills for a 2-year-old, even a typically developing 2-year-old, look very different from social skills for a 12-year-old. So as the person making the diagnosis and evaluating the child as they get older, we're always trying to keep those two things in mind. How do these social skills compare to what we expect for this child's age? Basically, we have these two core symptom domains. So now I'm going to go into the symptoms in a little bit more detail. So this first category is the category of difficulties or weaknesses in social communication and interaction. And for this, there are only 3 symptoms. They're relatively broad. But to meet criteria for a diagnosis, a child must have all 3 of these symptoms. So the first is deficits in social emotional reciprocity. And I put that in bold because really the whole time we've had such a thing called autism, we've thought of this as being the core of the diagnosis. This is really the central part. So I'm going to spend a little time explaining what that is. And I'll start, most of my examples are for pretty young kids, but I'll also try and explain that for older kids too. So one thing that I might do in an evaluation pretty commonly is play peekaboo with a kid. See if I can get a little game of peekaboo going. Because peekaboo is really a reciprocal game, right? An adult does something, and then a child responds. An adult does something again, a child responds again. So there's this back forth. That's really what we mean when we say reciprocity. So there's different degrees of severity here. So on the one hand, we might have a kid who is pretty unresponsive. So I'm all excited, and I come up to the kid, and I peekaboo, and before I can even pull the blanket down, the kid has crossed the room to the other side of the room. So that kid is not engaging with me. And then I walk over, and I'm all excited, I peekaboo, and the kid's gone again. So that child is having some difficulty with reciprocity, right? They're not responding to my bids to interact with that child. So that's one way it can look. But we're also looking for subtler weaknesses. So actually, probably the more common thing I see in 2 to 3-year-olds is that I'm excited, and I'm very engaging, and I've got my blanket up, and I'm going to do peekaboo, and I get a huge smile, and it feels great, and the kid's there, and then I put the blanket up, and then nothing happens, right? So now the kid has lost interest. So in that example, the child responded to me, we had a connection, but what didn't happen was that the child did not try and keep the interaction going. So that's more of a subtle weakness in reciprocity, where we have a good response, but we still don't really have that back and forth. So that's the kind of thing that we're talking about in very young kids. Now, as we get older and social skills change, one of the big things that we're looking at in kids who have language skills is the ability to maintain a back and forth conversation. So as adults, as children, as teenagers, the ability to do that back forth of a conversation is really characterized by reciprocity. Other things might be the ability to understand and respond to other people's emotions. So not even language, but actually kind of that nonverbal social back and forth that we have with each other. So those are some of the things that fall into that category. This is weaknesses in nonverbal communication behaviors used for social interaction. So it's related to that first one, but we're now talking about specific nonverbal communication skills. So the most classic thing that falls in here is eye contact, poor eye contact. So eye contact is a nonverbal communication skill that's used to regulate social interactions. We use eye contact to get people's attention. We use eye contact to show our interest in other people. And we just kind of spontaneously use a lot of eye contact. So children who have reduced eye contact, that would fall into this category. But it's not just eye contact, so other things that might fall into there. One of the classic red flags of autism, so something that we look for in very young children, is failure to point. So children who are not pointing out things in their environment, like, hey mom, look at that airplane, or I want some chips. Doing that kind of nonverbal thing is much less common in children with autism. And another thing that we see often are reduced facial expressions. So children who either have very exaggerated facial expressions or just aren't using that range of facial expressions like smiling and frowning, but also looking embarrassed or surprised or disgusted and really having a range of facial expressions. So that's the kind of thing that falls into that second category. These are things that we can really pick up on during an observation of a child because they happen a lot. The third symptom in this category, and again these are all required, are difficulties developing and maintaining relationships that are appropriate to developmental level. So the appropriate to developmental level really applies to everything, but in this one in particular we want to think about what are appropriate peer relationships, because we're really mostly talking about peers in a very young child. That's hard to say. So in a 2 to 3-year-old, usually all we're looking for is does the child show some interest in other kids? Are they approaching other kids on the playground? Are they responding in some way when other kids are approaching them on the playground? So this is very hard to assess in young kids. As we get older, we want to think about what are the child's relationship with other kids at school, with kids in other contexts, that kind of thing. And we're not talking about relationship with parents. So relationships with parents and what's known as attachment is intact in children with autism. For a long time, people thought that that had to be a problem, but actually the research hasn't shown that. So that's why we exclude relationships with caregivers when we're assessing that symptom. Second domain, so this is the domain that's the more unusual behaviors. Now, there are 4 symptoms in this domain. They're also somewhat broad, but you do not have to have all 4 of these symptoms. You only have to have 2 to meet criteria for a diagnosis. So I'm going to go through them a little bit more quickly. The first is, I think, probably the most classic thing. So this is repetitive speech or behavior. This can come in many, many different forms. So one thing your children might do is repetitive movements of their hands or body. So kids who flap their hands a lot, kids who wiggle their hands near their eyes, kids who jump or spin very repetitively, that falls into that first category. But it doesn't have to be physical movements. So another very common thing is repetitive speech. So children who might say lines from TV shows or books repeatedly, but also children who just repeat things. So some children will, you're playing with them and they do something great and you say, great job, and then they say, great job. And so that falls into this category of repetitive speech as well. The second category is rigidity in routines and behavior and resistance to change. This is something that can really persist throughout life and take different forms. So in young children, we might see difficulty with change and transitions. This actually throughout the life we might see this. So difficulty going from the house to out of the house. So even if your kid loves the playground, the fact that you were in the house and now you're going somewhere else to the playground, that change can cause a lot of distress. Another common thing we see is very strict routines. So pajamas have to go on before teeth brushing, and if for some reason in your family you really want to brush your kid's teeth before the pajamas, that's going to be a problem. So that's the kind of thing that falls into this second category. As kids get older and they learn to be more flexible, one thing that we see a lot is kind of rigid thinking. So thinking of things in very black and white terms, and that would also fall into that category. So you might not see it, but when you're talking to your kid, you might be like, you're a little bit rigid about that, or you're a little bit black and white. So that kind of flexibility is something that we work on with older kids a lot. Third category are restricted interests. So this is the idea that your child might have some interests that are either very extreme in their intensity. We take a 3-year-old who's really into Thomas. Well, a lot of 3-year-olds are really into Thomas, so that interest is not unusual, but your child it's the only thing they want to talk about. They have to carry a Thomas around. They're always drawing Thomas. So the degree of that interest is very high. It could be that, or it could be something that is sort of unusual, so that an interest that you don't see in other children that age. So an interest in stop signs, for example, or in older children, an interest in subway maps. And the subway maps example I'm thinking of because I worked with a young man once who was a young man when I lived in New York City, and I saw what is pretty common, which is that a lot of times these interests don't really have a function. So a lot of us have interests that don't have a function, but the interest is a lot of times in these very small details. So this young man, who was just lovely to talk to, knew everything about the subway. He could tell you all of the stops on every line in the New York City subway, which is impressive, and much more than that. But he actually didn't know how to get from his home to his school on the subway, even though he was a young man. He was in his early 20s. So sometimes you see that those interests don't translate into something functional, although sometimes they do. So that can be a tricky one sometimes in the older kids. Last symptom in this category is sensory interests and aversions. This is actually a new symptom. This is the only symptom that is truly new in our revision to the diagnostic criteria. And this came out of the fact that many parents were reporting that their children have sensory aversion, so things like covering their ears when they hear loud noises or being really sensitive to the textures of their clothing. But that's the aversions part. But then also interests, like really liking the feeling of smooth things, or just liking to watch things drop or listen to things drop. So parents were reporting this a lot. We were thinking about it when we were making diagnoses, but we didn't have a symptom for it. So now that is there. So another thing that we've added to the way that we make a diagnosis is this idea of level of severity. This hasn't fully caught on, but at some point you might start seeing this in your children's reports. And this is the idea that we are very aware that there are differing degrees of severity of these symptoms. How much do this, not just are the symptoms present, but how much are these symptoms affecting your child's ability to function? So what we've tried to do is start categorizing these things. So we have those two domains of symptoms, social communication and repetitive behaviors and interests. And for each of those, we try and take an estimate based on what we know about your child's functioning in the world about how much support they need for each of those things. So do they need a lot of support for their social communication skills or just a little bit? We don't have much data on this, so we don't know how this is going to work. Our hunch as clinicians who have seen a lot of kids over time is that these things are going to change over time. While we don't expect the diagnosis itself to really change much, we do believe that levels of support are going to change a lot based on your child's environment and development. So we're still figuring out what this means. The other thing that we're trying to specify each time we make a diagnosis is whether the child has some associated language impairments or intellectual impairments. In young children, we almost always see a language impairment because most children with autism when they're very young have language delays, although that does change over time too. The other thing I want to cover are accompanying conditions. So these are things that as parents it's good to have your eye out for and to talk to your providers about if you have any concerns about these things. So one is seizures. Children with autism do have a higher risk of seizures and seizure disorders. There's a wide range of estimates for how many kids actually have seizures. And we do know that if children have significant intellectual disabilities and if there's a family history, of course, of seizures, that they're more likely to be at risk for that. But in general, even children who don't have intellectual problems and don't have a family history, their risk is elevated, probably about 6 to 8%. Seizures can come in different forms. So everyone is familiar with what we call grand mal seizures, which is when there's a lot of movement of the body. Those are hard to miss. But there's also what are known as absent seizures, which is when children basically lose consciousness, but their muscle tone and their bodies stay the same. So you might just see that all of a sudden your child is not paying attention to something anymore, or they're very still, or they look like they're zoning out. That can be very hard to distinguish from typical behavior. But if that's something that you've noticed and you're concerned about, it's definitely worth bringing up with your pediatrician because children with autism do have a higher risk of that. And while it won't harm them in the moment to be losing consciousness, it interrupts what they're doing, it interferes with their learning. So we definitely want to address that. Okay, the other thing, it has become standard practice to screen children with autism for genetic disorders. Probably estimates are that about 10%, maybe a little bit more, of children with autism have some underlying genetic abnormality that can be detected. Now that's a hard one, and Dr. Kruger, our pediatrician, will be here later if you have questions about that. The reason that that's important to look into is that sometimes specific genetic abnormalities can be associated with other health conditions that it's good to know about in advance. So that's why it's become standard practice to screen children for genetic disorders. Other common accompanying conditions. So one is GI disorders. There's been an increased interest recently on the connection between GI problems and autism. We still don't really know the answer to that, but one thing that we do know is that many parents report that their children have GI problems. It may be more than in typical kids, it may not be, but what we also know is that kids with autism have a hard time communicating. And I think everyone here can imagine that if you are in pain somewhere in your body and you can't express that, that's very distressing. So that's why when kids seem a little bit off, a little bit funky for them, we want to think, oh, maybe they're having some constipation or some other GI problem that they're not able to express. Even in kids with pretty good language skills, a lot of times kids with autism have a hard time just kind of localizing things in their body and describing their internal experience, even if they have the language. So if you feel like, why can't you just tell me what's going on? That could be why, that they're having a hard time pinpointing what's going on. So always worth bringing up with your pediatrician if your kid seems out of sorts. Actually, anytime your kid seems out of sorts, it's worth bringing up with your pediatrician. And the other thing that kind of falls under this category of GI disorders is picky eating. So because kids with autism tend to have those sensory aversions, we see a lot of picky eating, especially as kids get older. So picky eating can be a problem. It depends on how your family feels about it. And then, of course, it depends on nutrition. So if your kid is really just limiting themselves to only white foods, for example, we see that a lot, that's something to bring up with your pediatrician. Just trying to decide when do we need to do something about this. The other thing is sleep. So children with autism do have a harder time than typical with both falling asleep and staying asleep and waking up early in the morning. So sleep can be very difficult. Sleep can be very hard on families when kids have sleep problems. And then also for the child, him or herself, as we all know, when we're sleep deprived, we have a harder time learning. And a lot of times your kids are doing some pretty intensive learning during the day. And we have a hard time paying attention. And we have a hard time with our emotions, with regulating our emotions and kind of dealing with the things that are a little bit harder than normal. So sleep is super important, and we have a handout on that. There's also an excellent toolkit from Autism Speaks. For those of you who are not familiar with the Autism Speaks toolkits, they're similar to our handouts where they describe advice, and the sleep toolkit kind of walks you through some behavioral strategies, which is basically what we would recommend to psychologists for dealing with sleep. Other accompanying conditions. These are psychological diagnoses that are often seen in kids with autism as well. So the first is language disorder. And as I mentioned before, many young children, especially with autism, have language delays, the majority of children. Many children continue to be delayed in their language relative to their peers, although I think right now estimates are that a pretty large majority go on to develop some level of fluent speech. And there's a wide range. So we have people with autism who have just genius levels of language, down to those who still have trouble speaking at all. So we have a wide range there. And then the other thing is intellectual disability. So intellectual disability basically just means that your child's cognitive skills, their ability to reason and figure things out, are not at the same level as other children their age. Right now, estimates are that about 50% of children with autism have some intellectual disability in the school-age years. So that's something that we want to pay attention to because it's really important to know for your child's educational planning. And these two, ADHD and anxiety, really apply as kids get older. So ADHD is basically characterized by kids who have difficulty paying and sustaining attention, along with some impulsivity or hyperactive behaviors. ADHD is hard for us to sometimes distinguish from autism symptoms because children with autism also can appear to have difficulty paying attention because they're making poor eye contact, for example, or they're more interested in the things in the room than the people. And they can have things that look like hyperactive behaviors. They might just be those repetitive movements. So these two diagnoses are hard for us to distinguish. They're both considered neurodevelopmental disorders. And actually, a way that they're treated, especially in school-age kids who are more likely to receive a diagnosis of ADHD, is similar because we're using academic supports and we're making things more structured and we do similar things. That said, it's important if you are concerned that your child has some symptoms of ADHD to bring that up because there are medication treatments for ADHD where there are not for autism. And then the final thing I want to mention as far as an accompanying condition is anxiety. And you can put depression in here too, although anxiety is more common. So there's kind of this sad paradox, that, to me it's sad, that happens in kids with autism, which is that As they get older, they get more verbal. A lot of times their autism symptoms go down, and their autism symptoms are getting better. And then as they're getting better, they're starting to develop some insight, and they're paying attention to their relationships. And they're realizing that they're a little different and that they're having a hard time in their relationships. And I think everyone here has probably had a hard time in their relationships at some point. And when you realize that, that stings. And so that's the kind of this double-edged sword that I think can happen as we enter those late school age and adolescent years. We have decreasing autism symptoms sometimes, but emerging depression and anxiety as that insight and awareness increases. So that's something to pay attention to and to take very seriously if your kid, if their mood seems to be changing, if they're more anxious or they're sounding more hopeless to you, or they're starting to point out that they are feeling very different from other people. Very quickly, the prevalence of autism has been changing. Our most recent estimate from this year put it at about 1 out of 68 school-aged children. And the ratio is very high, highly in favor of boys to girls, so it's about a 5-to-1 ratio, meaning that about 1 out of 54 boys in school-age years receives a diagnosis on the autism spectrum, somewhere on there. As I mentioned, the prevalence has increased, so our first estimates of the diagnosis about 15 to 20 years ago were about 1 out of 2,500. It was thought of as extremely rare, but now it's thought of as fairly common. So why has there been this increase? We don't know the exact answer to that. First is that it's very hard to estimate the prevalence of autism, so the numbers can change just because it's hard to estimate. And we also know that the rates vary by source. So we're sort of comfortable in these estimates, but they're not perfect. Most people think that changes in definition is the biggest factor in why there's been this increase. And I always like to remind people when I'm talking about prevalence that autism was actually not its own diagnosis until 1980. So it's relatively new, and we're still figuring out what this means. And there's been increased awareness. So children who might have just been thought of as kind of the quirky nerd, we now think, well, actually, they fit under this collection of symptoms that we call autism spectrum disorder. So that's increased the rates as well. And so if these rates are increasing, but we think that it was about the same number of people who actually had autism in the past, where were they before? So we think that a lot of people were probably diagnosed with something else. So there were a lot of children who had more intellectual problems or more severe autism symptoms who would have been diagnosed with mental retardation. We might have just had kids who were diagnosed with schizophrenia, that was kind of our catch-all for unusual behaviors, or something like a conduct disorder, like an acting out disorder. Children might just not have received the diagnosis. They might have just been accommodated within their families and they weren't expected to function in society, or they were institutionalized or ostracized and kind of treated pretty poorly. Now, in general, we're serving children, adolescents, and adults in community settings and within the family. So they're much more a part of our world. And I think most people who don't have a child with autism, who just walk around the world, know someone who has autism or know someone whose child has autism. So we're much more aware of the diagnosis now. So the big question of the day, of course, is what causes autism? And the answer, unfortunately, is that we don't know. We've been trying very hard to figure it out. We've ruled a lot of things out, but we haven't really figured out what actually causes it. We know there's no single cause. So we know that the cause of autism is very multifaceted, which is what makes it so hard to put our finger on it. We also know there's a significant genetic component. We know that some genes themselves make people more likely to have autism. And we also know that some genes might leave children more vulnerable to environmental triggers. We don't have these things figured out exactly, but we're starting to understand the general patterns. Some important things that we have tested thoroughly and ruled out, one of them I mentioned already, which is that autism is not caused by bad parenting. Of course, that was the first theory, that it had to be caused by bad parenting. So we've really looked into that, and we know that that is not the case at all. The other thing that's been more recent that's been tested and ruled out is vaccines. So there were some theories that vaccines, all different types of vaccines, could cause autism. That has been tested for about 15 years now and pretty much ruled out. You all know this, but I like to talk about why it's important to make a diagnosis. Why does this label matter? And for many of you, the diagnosis confirms your own suspicions or what you've really known for a long time about your child. And of course, the diagnosis doesn't change your child, but it does help us in many ways. So one is that it helps us understand behavior and development. So if you know your child has autism and you know that sensory aversions are part of autism, even if you had never seen it before, you walk into a loud store and suddenly your kid is cowered on the floor covering his ears, you might think about that differently if you know that that's part of the diagnosis. Similarly, as your child moves on and starts to develop new skills, it helps us pay attention to places where they might have challenges and also places where they might really excel. So it helps us pay attention to those things that we might not have really thought about in the same way. Similarly, it suggests a roadmap for treatment, so we know what treatments have been really helpful in improving autism symptoms and helping kids with autism learn. So we can, with that diagnosis, we know right where to start. So we're going to tweak it for your individual child, but in general, we know what to do. And then from a very practical perspective, having the diagnosis helps connect your child to specific services and get access to those services. And as we're starting to do today, many parents find it helpful to link together with other parents with children with autism to have that nice support and share those experiences together.